So the thing that, as Catherine said, that the symptom that patients with brain tumor present with classically would be a seizure. So a seizure is the one thing that would make me worry that an adult patient presenting with a seizure, you really need to do a scan to exclude an underlying tumor. And we have rapid access for seizure clinic pathways set up in most places in the country. It obviously does not have 100% coverage, but if you have a patient who you think has had a new onset seizure, that would be a very reasonable indication for a 2-week wait referral, say, an adult patient presenting with a seizure.
Are you just talking about or are we talking about different absent seizures or temporal lobe seizures? What sort of things are we talking about?
So you don't necessarily have to have that degree of precision in terms of diagnosing a seizure. Typically, we're talking about an episode of transient loss of consciousness. And the only distinction you need to make is between faint and fit. So if it is not vasovagal syncope, so if you cannot diagnose vasovagal syncope, then that patient needs to be seen in secondary care. If you can't diagnose vasovagal syncope, just do a 12-lead ECG, that is normal, patient's fine, they can go carry on with their life. But if you cannot diagnose vasovagal syncope, then the distinction lies between a cardiogenic syncope or a seizure. So depending on your level of suspicion of either of those two things, you refer to cardiology or neurology urgently. And as I said, the first treatment pathway is well established here in Manchester as well as in other places, but it might not be the same everywhere. But I think that would be a very reasonable thing to refer on a 2-week wait pathway. The second thing is this more insidious presentation with progressive neurological deficits. And that's a more subtle thing. And then typically that would be somebody who maybe hasn't consulted their GP very much, and they're brought along by a family member saying, I'm a bit worried about this person. They're a bit more forgetful, they seem to be getting more muddled, they can't get their words out properly, etc., etc. That may present a little bit more acutely and be suspicious of a transient ischemic attack or a stroke, which again obviously has its own urgent referral pathway. So our stroke team does pick up tumors along in the acute stroke presentation, as well as in the TIA clinic when they have their brain scans, they pick up those. So the first seizure type presentations, TIA type presentations, there are well-established pathways for referral, and these patients may well be picked up in those clinics. The headache presentation with a suggestion of progressive, over weeks to months, progressive neurological dysfunction is the one that would need fairly urgent referral. But as I said, it's pretty uncommon for that to happen. In most cases, when you present with a patient presenting with a headache, the key thing is to see if they have migraine. I mean, I always try and diagnose migraine because that's one thing you can treat. And most people who report progressive headaches to their GP are going through a bad patch of their migraine. When they say progressive, what they mean is it's been getting worse in the last couple of months, but they've always had it. Maybe they had a couple of days of headaches around their periods, or when they're stressed, or when they haven't eaten all day and things like that. But for whatever reason, they're going through a bad patch.
Yeah. And Catherine, I think we talked a little bit, and I think one of our patients in the brain tumour module has got some weird epilepsy type symptoms that you said are quite easy to miss. Can we just talk a little bit more about that?
Sure. So again, it's about being vigilant, and it's about just sort of smelling around, just feeling that something's not right about this person. So if a tumor is particularly in the temporal lobe, so symptoms of seizures depend on, again, the anatomical location in the brain. If it's in the frontal lobe near the motor cortex, that's when people are getting generalized seizures or partial seizures involving their arm or leg. But if it's in the temporal lobe, you can get complex partial seizures, and that can manifest classically as olfactory hallucinations. So people smelling unusual smells or smelling things that other people can't smell, classically burning rubber. And also having the other part of that can be a feeling of sort of impending doom or a feeling of deja vu. And again, if we're aware that those can be really quite concerning signs. It's just something else to be vigilant for and be aware of.
And what about the overlap with dementia? Because some of the things that you're describing, we would notice with patients who've got early onset dementia. How do we start to differentiate that?
So the key thing about dementia is neurodegenerative processes progress at a much slower rate. So we're progressing over months to years rather than weeks to months. Anything that is rapidly progressive is what we would be suspicious of for a rapidly growing tumor like a glioblastoma. But in the right sort of age group, if you have a more slowly progressive cognitive disorder, then obviously you think more dementia than brain tumor. Just to add to what Catherine said about the temporal lobe epilepsy, so you have the other three lobes, the frontal lobe, which is mainly motor, so you tend to get limb symptoms, the parietal lobe, which is sensory, so you tend to get funny sensations in the arms and legs, and the occipital lobe, which produces visual phenomena. The temporal lobes is a part of the brain where all of these sensations and motor activity are integrated and attached to emotions and memory. So a key feature of seizures coming from the temporal lobe would be a strong emotional component or a strong memory component. So deja vu or fear or panic sensations, typically sensation in the stomach that rises up associated with abnormal taste and smell, in which the patient goes blank and they can make fiddling movements of their hands. That's thing called automatism. So this used to be referred to as psychomotor seizures back in the day. We then changed the name to complex partial seizures and now called focal unaware seizures, but it means the same thing. It's a focal seizure coming from the temporal lobe.
Can I just mention, Sarah, as well about the age group in which brain tumours are diagnosed? Because again, I think we often think about brain tumours in children and in young adults. And we do see brain tumours in children, but that's really because children are proportionately getting much less cancer of other types. But demographically, malignant brain tumours, glioblastomas, are much more common in the older age groups. They're slightly more common in men and more common in people in their 60s, 70s and 80s. And so they can present with those symptoms which could be written off as dementia or stress or depression or infection or numerous other things. And so for men in their sort of their 60s, 70s, 80s who perhaps aren't very keen to see their doctor with symptoms of that type, and again, this is one of the cases that we've got on the Gateway C, in the Gateway C module, family being concerned about behavioural change and cognitive change. But again, back to the fact that the key thing is progression over a 2 or 3 month period with really hard, obvious change over that time. But just again, being aware that it is that sort of subtle build-up of symptoms coming in that we often don't necessarily think of as being related to a brain tumour, but in fact are much, much more common than the very sort of dramatic morning headaches that everybody tends to think of first.